Okay, let's just dive right in. We are tackling a topic today that is, well, it's probably the single most whispered about subject in men's health.
Oh, for sure.
It's the punchline of 1,000 bad jokes. It is the source of just immense private anxiety. And, usually it's treated as just a lifestyle inconvenience.
Right, something you just sort of deal with on your own.
Exactly. But
Yeah.
what we have in the stack today, it completely reframes that whole narrative. We are not just looking at a lifestyle issue here.
Not at all. And if there is one thing I really want people to take away from the research we've analyzed, it is that this condition, erectile dysfunction, or ED, is not just about what happens or doesn't happen in the bedroom.
Mm-hmm.
It is a systemic issue. It is a massive flashing red light on the dashboard of your overall health.
A flashing red light. I like that. We're looking at source material that literally describes ED as a canary in the coal mine.
It really is.
And frankly, the complexity of it just blew my mind. I think most people, myself included, kind of think, okay, you take a little blue pill and problem solved.
Yeah, that's the common perception.
But the physiology involved,
Yeah.
it is like a NASA launch sequence. I mean, it's
Yeah,
incredibly intricate.
That is a perfect analogy.
Mhm.
It really is. You have 4 distinct physiological systems that have to work in absolute perfect harmony.
4. Not 1, but 4.
And if just one of them is slightly off, the entire launch is scrubbed.
The launch is gruff.
So what we're going to do in this deep dive is take apart those 4 systems piece by piece.
Mm-hmm.
We'll look at the surprising things in your own medicine cabinet that might be sabotaging them. I mean, drugs you would never, ever suspect.
Right.
And then we'll walk through the whole hierarchy of treatments, from, the pills all the way to prosthetics.
We have to start with the definition, though, because I think guys can be a little hypochondriac about this.
Oh, absolutely.
You have one bad night, maybe you're tired or you're stressed, and you immediately think, that's it, I have a medical condition. But the clinical definition we found in the source material is actually quite specific, isn't it?
It's very specific. It is not just an occasional glitch.
So what is it, clinically?
The medical literature defines erectile dysfunction as the persistent failure to achieve a penile erection suitable for sexual intercourse.
Okay, persistent is the key word there.
It's the most important word. And the guidelines actually specify a time frame.
Oh, really?
Yes, this has to be occurring for a minimum of 3 months to be clinical classified as ED.
3 months, that's a significant amount of time.
It is.
So a bad weekend or, a stressful week at work, that doesn't count as a clinical diagnosis.
Precisely. Everyone has off nights. That's just being human. But if this is a consistent pattern that lasts for a quarter of a year, that's when we move from I'm just tired to, okay, we may have a pathology here.
And what about the terminology? I hear the word impotence thrown around a lot.
Yeah, and patients often use that word, impotence. But medically, we really try to stick to ED.
Why is that?
Impotence carries a lot of pejorative baggage. It implies a total lack of power, a moral failing almost.
Right, I can see that.
Whereas ED is a spectrum of dysfunction. It's more precise, and it's certainly less judgmental.
And as we said, this is a system failure. So let's get into that why hook we mentioned at the top, the canary in the coal mine.
Yes.
Why is a diagnosis of ED potentially life-saving? It really does feel like a leap to go from sexual performance to life or death.
It feels like a leap, but anatomically, it's a straight line.
How so?
Because the penis is, at its core, a vascular organ. It's filled with tiny, tiny blood vessels, and those vessels are much, much smaller than, say, the coronary arteries that feed your heart.
Okay, so it's just a matter of scale. The pipes are smaller.
Exactly. The pipes are tiny. We're talking 1 to 2 millimeters in diameter in the penis versus 3 to 4 millimeters in the heart.
So double the size in the heart.
At least.
Right.
So if you have underlying vascular disease, arteriosclerosis, plaque buildup, basically the clogging of the pipes, where do you think it's going to show up first?
In the smaller pipes.
In the smallest pipes. It's going to show up in those tiny vessels of the penis years, sometimes 3 to 5 years, before it clogs the bigger vessels of the heart and causes chest pain or a heart attack.
Wow. So it is literally an early warning system. Your body is screaming at you that the flow is restricted long before you get the classic signs of heart disease.
It is the ultimate early warning system. If you have what we call organic vascular ED, your body is telling you that your entire circulatory system is compromised.
And ignoring it.
Ignoring it isn't just about your sex life. It's about ignoring a potential cardiovascular event down the road. It completely transforms the conversation from performance to survival.
That raises the stakes considerably. So to really understand how it fails, we have to understand how it works. And this is where we get back into that NASA launch complexity.
Yes, the four-system balancing act.
I want to circle back to that analogy because for most guys, I think the experience is just binary. You know, it either happens or it doesn't. We don't really think about all the cockpit checks that have to happen first.
Right. And there are a lot of them.
But you're saying this is actually a massive physiological coordination effort.
It is incredibly complex. And I think if men understood the sheer engineering required for this to happen, they'd be a lot more forgiving of their own bodies when it occasionally fails.
So it's not just about blood flow.
That's the end result, sure. But to get there, you need 4 distinct systems firing in a specific, perfect order.
Okay, let's break it down. Before we get to the systems, let's just visualize the hardware itself. What are we actually working with anatomically?
Okay, let's strip it down to the absolute mechanics. The penis contains 3 cylinders of spongy tissue. You have 2 main ones, the corpora cavernosa.
Okay.
Those are the main erectile bodies that run down the sides. And then there's one smaller one, the corpus spongiosum, which surrounds the urethra to keep it open.
And these are filled with, what did the source say, sinuses?
Interconnected sinuses, yes. The best way to think of them is like a sponge, a very dense, complex sponge.
A sponge. Okay, I can picture that.
A dense, dry sponge that's wrapped in a very tough, non-stretchy fibrous casing. For an erection to happen, that sponge needs to soak up an incredible amount of blood very rapidly.
And that pressure is what creates the rigidity.
Exactly. The blood fills the sponge, it pushes against that tough outer casing, and that's what creates the hardness. But here is the trick, the paradox of it all.
Okay.
The sponge is naturally squeezed shut. The default state of the penis is contraction, or flaccidity.
So the body has to actively tell it to let go, to relax.
Precisely. And that brings us to the 4 systems.
All right, let's name them. System number 1.
The vascular system. You need healthy pipes and enough blood pressure to physically get the blood there.
Okay, plumbing. Got it.
System number 2. The nervous system. The electrical signals have to travel from the brain and the spinal cord all the way down to the tissue to tell it to relax and let the blood in.
The wiring.
The wiring.
Yeah.
System 3. The hormonal system. Testosterone and other hormones playing their role in drive, desire, and maintaining the health of the tissues.
And the 4th one. This is the one you said is often overlooked.
The 4th one is psychological receptivity.
The software.
Exactly, the software. Your hardware can be absolutely perfect, great plumbing, perfect wiring, but if the software, the desire, the lack of anxiety isn't running properly, the go signal never gets sent.
It's incredible that it works at all when you lay it out like that.
It really is a marvel of biological engineering.
Let's drill down into the nervous system part for a second, because the chemistry described in the source was pretty dense. I saw terms like acetylcholine and CGMP.
Yes.
Walk me through the countdown. Let's say T-minus 10 seconds. What happens when the brain says go?
Okay, so you perceive a stimulus. It could be visual, tactile, even just imaginative. Your brain processes that and sends a tiny electrical signal down the nerves in your spinal cord.
And right there is the first potential failure point.
The very first. If you have a spinal cord injury, or if a condition like diabetes has frayed those nerve endings, the launch is scrubbed right there. The signal never even leaves the tower.
Okay, so let's assume the wires are good. The signal travels down the spine and hits the nerves in the pelvis. Then what happens?
Then we switch from an electrical signal to a chemical one. This is the neurotransmitter cascade.
Right.
The nerve endings in the penis release a chemical called acetylcholine. Now, you don't need to memorize the structure, but you need to know what it does. It's the starter pistol.
It kicks the whole thing off.
It kicks it off. Acetylcholine triggers the cells lining the blood vessels, the endothelium, to release the real VIP of this party, a gas called nitric oxide.
Nitric oxide! I feel like I see that on the label of pre-workout supplements at the gym.
It's the exact same principle. Nitric oxide is a potent vasodilator. It's a signaling molecule, a gas that literally tells the smooth muscle cells in the arteries of the penis, relax.
And this is that paradox you mentioned. To get hard, the muscles actually have to go soft.
Physiologically, yes. It's counterintuitive. We associate flexing and tension with hardness. But here, it's the opposite.
Explain that again, because it's a key point.
When the smooth muscles inside that sponge, the corpora cavernosa, are tight or constricted, the sinuses are squeezed shut. Blood can't get in. The sponge stays dry. The penis is flaccid. That's the normal state.
So the nitric oxide hits, and those muscles just let go.
They completely relax. And when they relax, the arteries open wide and blood just roars into that sponge under pressure, filling all those empty spaces.
Okay, so nitric oxide opens the floodgates. But what keeps them open?
That's the next step. Nitric oxide triggers the production of a secondary chemical called cGMP, cyclic guanylate monophosphate.
cGMP.
I
Okay.
want you to remember cGMP. Think of cGMP as the guy physically holding the floodgates open. As long as cGMP is present in high concentrations, the smooth muscle stays relaxed, the arteries stay wide open, and the erection is maintained.
So cGMP is the hero of the story. It's the chemical that keeps the party going.
It is,
Yeah.
but, and here's the critical catch, the body is all about efficiency and balance. It doesn't want the floodgates to be open forever.
Right, that would be a problem.
A big problem. So it sends in a cleanup crew, a specific enzyme called PDE5, phosphodiesterase type 5.
Phosphodiesterase.
Right. And PDE5 has only one job in this context, to find and destroy cGMP. It's the anti-erection enzyme. It comes in, breaks down the cGMP, the muscles tighten up again, the blood flows out, and the party is over.
So it's a constant battle inside the tissue. You have nitric oxide making cGMP to keep the door open, and you have PDE5 trying to slam it shut.
That is the perfect way to visualize it. In a healthy, functioning male, during stimulation, the production of cGMP massively outpaces the destruction by PDE5, so the open signal wins.
And in a man with ED.
One of two things is happening. Either he's not making enough cGMP to open the door in the first place, maybe due to nerve damage or vascular disease, or his PDE5 is just overactive and slamming the door shut too fast.
Which finally explains why the drugs are called PDE5 inhibitors.
Precisely.
They aren't opening the door, they're just handcuffing the guy who's trying to slam it shut.
That's it, exactly. They don't create the desire. They don't start the process. They just protect the cGMP that your body makes naturally in response to stimulation.
That makes the mechanism so much clearer. So knowing how incredibly delicate this balance is, let's talk about what breaks it. The source divides the causes into two big buckets, organic and psychogenic.
Right. Or as we called them earlier, hardware and software problems.
Let's start with the hardware, the organic ED. This is usually where doctors look first, especially in older men. It's a physical breakdown in one of those first three systems.
And the vascular system is by far the most common culprit.
The plumbing.
The plumbing. If you have peripheral vascular disease, arteriosclerosis, or essential hypertension, high blood pressure, you physically cannot pump enough blood into the corpora cavernosa with enough force to create rigidity. It's a simple hydraulics issue. The pipes are clogged, or the pressure just isn't reaching the destination.
And then there's the wiring, the nervous system. You mentioned diabetes earlier. How specifically does diabetes mess with this?
Diabetes is just brutal on the nervous system over time. Chronically high blood sugar is like acid to the myelin sheath, which is the insulation around your nerve fibers.
So it shorts out the wires.
It's called neuropathy. The brain is shouting, go, but the message gets garbled or dissipates before it ever reaches the penis. The same thing can happen centrally, too, if someone has had a stroke or a spinal cord injury.
It all just keeps connecting back to these bigger systemic health issues, diabetes, heart disease. They're the major drivers here.
Absolutely.
And then the third organic cause is hormonal, which I feel like this one gets all the marketing attention, low T.
It does get all the marketing, but clinically it's often secondary or a contributing factor, not the sole cause.
So it's not the first thing a doctor would suspect.
Not usually, no. Hypogonadism, which is the medical term for clinically low testosterone, can cause ED, but it almost always presents first as low libido. You just don't have the drive or desire. And if the software isn't running, the hardware won't engage.
Okay, so that's the hardware. Now let's look at the software psychogenic ED. The source listed some really fascinating factors here. It's not just being stressed out from work.
No, it's much more nuanced than that. We're talking about a breakdown in the patient's psychological receptivity to sexual stimuli. This can be blocked by something like reactive depression or sedation from other meds. But the big one is performance anxiety.
That vicious cycle, I think a lot of guys can relate to that. You fail once, you start to worry about failing again.
And the worry itself causes the failure.
How does that work biologically?
It's pure adrenaline. Anxiety releases adrenaline and noradrenaline into your bloodstream. Those are powerful vasoconstrictors.
Vasoconstrictors, so they do the opposite of nitric oxide.
The absolute opposite. They clamp blood vessels shut. It's the body's fight or flight response. Your body is saying, this is not the time to have sex. We need to run from a tiger. So biologically, being anxious about getting an erection makes an erection physically impossible.
It's a self-fulfilling prophecy.
The ultimate self-fulfilling prophecy.
There was an interesting silver lining note in the source regarding psychogenic ED, though.
Yes, and this is really encouraging. Patients who have purely psychogenic ED generally have a much, much higher response rate to interventions than those with organic ED.
Why is that?
Because the plumbing and the wiring are intact. The hardware is fine. The signal is just getting jammed by anxiety or depression.
Mm-hmm.
And if we can unjam that signal, either with therapy or with a pill that gives them confidence, the system works perfectly again. It's much easier to fix than a clogged artery or a damaged nerve.
That makes a lot of sense. Before we move to the medications, we have to mention the lifestyle factors. The source was pretty blunt about two specific social habits that are just killers for this.
Cigarette smoking and excessive ethanol alcohol intake.
Let's take smoking first. How does that cause damage?
Smoking is absolutely devastating for vascular health. It's a direct toxin to the endothelium, that delicate inner lining of the blood vessels.
The place where the nitric oxide gets released.
The exact spot. So smoking essentially poisons the starting gate. It creates a brick wall for your erection mechanism, not to mention it accelerates the plaque buildup in the arteries themselves.
Right, alcohol. People usually think of it as a social lubricant, something that helps.
It lubricates the social interaction, sure. But physiologically, Shakespeare said it best in Macbeth. It provokes the desire, but it takes away the performance.
So it kills the mechanics.
It's a central nervous system depressant. It dulls the sensitivity of all the nerves we just talked about, from the brain to the penis itself. A little might lower inhibitions, but too much just shuts the whole system down.
Okay, let's pivot now to what I found to be the most surprising and, frankly, the most actionable section of this deep dive.
Drugs.
The saboteurs in the medicine cabinet. This is the part I really want you, our listeners, to pay close attention to.
This is so critical because often a patient comes in complaining of ED, and before we even think about prescribing a blue pill, we need to do a thorough review of what they are already taking.
And the source mentioned a fascinating clue here.
Yes. Non-adherence to other medications.
Meaning they stop taking their pills.
Exactly. If a guy suddenly stops taking his blood pressure medication, a good clinician should ask why. It's often because he noticed it was affecting his sexual performance, but he's too embarrassed to tell his cardiologist, so he just quietly stops.
And puts his heart at risk.
And puts himself at huge risk.
Let's go through the list of offenders, because some of these are incredibly common. Start with the big one, anticholinergics. This includes stuff like allergy meds and antidepressants, right?
Correct. Remember, we just said acetylcholine is the starter pistol for the erection. It starts the whole cascade.
Right. It's step one.
Well, many common drugs are anticholinergic. Their mechanism of action is literally to block acetylcholine in the body. They're jamming the starter pistol.
So if you block it, you stop the process before it even gets off the ground.
You never even get to the nitric oxide stage. This class includes many antihistamines, anti-Parkinsonian agents, and most of the older tricyclic antidepressants.
But there's a really important nuance here. The source made a clear distinction between different generations of antihistamines. You're telling me my seasonal allergy pills could be killing my sex life.
They absolutely can. If you are taking a first-generation antihistamine, think of the older drugs like diphenhydramine, which is Benadryl, the one that makes you really drowsy.
The one everyone takes to sleep on a plane.
Exactly. Those have very powerful anticholinergic effects. You're systematically dampening the chemical signal required to start an erection every time you take one.
So if I pop a Benadryl to help me sleep, I'm potentially sabotaging myself for the next day.
You are. But the good news is the second-generation ones, like loratadine, which is Claritin, or fexofenadine, which is Allegra, are much more selective.
What does that mean, selective?
They're designed to target the histamine receptors that cause allergies, but they mostly leave the acetylcholine receptors alone. They cause significantly less ED.
That is a huge takeaway. If you're struggling with ED and you're taking Benadryl every night, try switching to a Claritin. That's a $5 fix that could change everything.
It's a perfect example of a simple medication switch that can solve the problem without adding another pill.
Okay, what about the antidepressants? That's a major category affecting millions of people.
It is. And it's a tough one because you're balancing mental health with sexual health. The older tricyclic antidepressants are heavy offenders because of their anticholinergic effects.
And the newer ones, the SSRIs.
The newer class, SSRIs, selective serotonin reuptake inhibitors, cause less ED than the tricyclics, but they are not innocent. Their mechanism's different. It has more to do with serotonin's effect on libido and ejaculation.
But some are worse than others.
Yes, the source notes that within the SSRI class, paroxetine and sertraline seem to be the worst offenders for causing sexual side effects.
Okay, let's move to the next category. Dopamine antagonists. This sounds a bit more technical. What are these drugs?
These are drugs often used for severe nausea, like you get with chemotherapy, or for certain psychiatric conditions. Metoclopramide or phenothiazines are common examples.
And their mechanism is different.
Very different and very interesting. They inhibit something in the brain called prolactin inhibitory factor.
Okay, break that down. Prolactin. Isn't that a hormone associated with nursing in women? What is that doing in a man?
Men have low levels of prolactin naturally.
Yeah.
But its production is kept in check by this inhibitory factor. These drugs take the brakes off prolactin production.
So prolactin levels shoot up?
They go way up. And when prolactin goes up in a man, it directly inhibits testosterone production and release. It essentially creates a temporary chemical castration effect, which absolutely crushes libido.
Yikes. Okay, next category on the saboteur list. Estrogens and anti-androgens. I assume these are drugs specifically designed to suppress male hormones, maybe for something like prostate cancer.
Exactly, but it also includes some surprise drugs. Things like spironolactone, which is a blood pressure medication, or cimetidine.
Cimetidine, that's Tagamet, for heartburn. You can get that over the counter.
You can. And if you take it chronically in high doses, it has known anti-androgenic effects. It can block the androgen receptors. It's rare, but it definitely happens.
Wow. But let's get to the biggest one, the one that affects millions of men every single day. Blood pressure meds. The vascular saboteurs.
This is the tragic trade-off for so many men. You take the medication to save your heart from the effects of high blood pressure, but the medication itself might kill your sex life.
And the mechanism here is pretty straightforward, right?
It's very simple. These drugs are designed to reduce arteriolar flow. They lower your blood pressure. But remember, the erection is a hydraulic event. You need high pressure to inflate that sponge.
So if a guy is on, say, a beta blocker and he's having issues, is he just stuck? Does he just have to choose between having a stroke and having sex?
No, absolutely not. And that's the key message. He does not have to choose. There are safer alternatives. The worst culprits, according to the source, are the diuretics, the water pills, because they decrease your total blood volume, and the older beta blockers.
So what are the good guys in this category?
The source explicitly lists ACE inhibitors, calcium channel blockers, and alpha blockers as antihypertensives that have a much, much lower risk of causing ED.
So the conversation with your doctor isn't, I'm quitting my meds because I can't perform.
Never.
It's, Doc, I'm having some side effects. Can we try switching my medication from this beta blocker to an ACE inhibitor and see if that helps?
Exactly. That is an empowered, educated patient. Don't just stop taking your heart meds. Talk to your doctor about switching classes.
That is just such powerful, actionable advice. Okay, moving on. We've covered the why and the saboteurs. Now, how do we actually diagnose this? We mentioned that the partner is often the whistleblower.
It's so true. Men will often suffer in silence or denial for years. It's usually the partner who finally brings it up to the healthcare provider.
And what does the workup involve?
It starts with a conversation and usually some specific severity questionnaires, then a deep, deep dive into that medication list we just discussed. And then labs. We're checking lipid profiles for heart disease risk, glucose levels for diabetes, and of course, testosterone levels.
But there's a very specific safety protocol that was mentioned in the source material called the Third Princeton Consensus. This sounds like some kind of spy thriller, but it's actually a protocol all about the heart.
The Princeton Consensus is absolutely vital. It's a set of guidelines that emphasizes a simple fact. Sexual activity is physical exercise.
Sex is a sport.
Medically, yes.
Yeah.
It increases your heart rate, your blood pressure, your oxygen demand. The source material says it's equivalent to walking a mile in 20 minutes or climbing 2 flights of stairs briskly.
So not a marathon, but it's not nothing.
It's not nothing.
Yeah.
So before we give a man a pill that enables him to have vigorous sex, we have a responsibility to ensure his heart can actually handle the exertion.
And the consensus stratifies patients into 3 risk categories. Can you walk us through those?
Sure. At the bottom, you have low risk. This is your asymptomatic patient with fewer than 3 cardiovascular risk factors. These guys are cleared for takeoff. They can start treatment.
And at the very top?
At the top, you have high risk. This includes men with unstable angina, severe heart failure, or someone who has had a heart attack or a stroke within the last 2 weeks.
2 weeks? That's a very specific window.
It is. If you've had a major cardiac event in the last 14 days, your heart muscle is still healing. Sexual intercourse is absolutely contraindicated. Treatment for ED is completely off the table until they're stabilized.
Okay, so what about that big group in the middle, the intermediate risk?
This is the gray area. This is the guy who has maybe more than 3 risk factors or has mild stable angina or his heart attack was, say, 6 weeks ago.
So what happens to him?
The consensus requires him to undergo a formal treadmill stress test. We literally need to put him on a treadmill, hook him up to an EKG, and see if his heart can handle the metabolic equivalent of sexual activity.
So for some men, the path to the bedroom literally goes through the cardiologist's office.
In a very real medical sense, yes. If they pass the treadmill test, if they can get their heart rate up without showing any signs of ischemia or distress, they get reclassified to low risk and can start treatment.
And if they fail?
If they fail, they are reclassified as high risk, and the focus shifts from treating their ED to aggressively treating their underlying heart disease.
All right, let's assume our patient is cleared. Low risk. We are ready to treat. The first line of defense is the class of drugs everyone knows. The phosphodiesterase inhibitors, or PIs?
Yes, Viagra, Cialis, and their cousins. These drugs absolutely revolutionize the field.
And we talked about the mechanism. They handcuff that PDE5 enzyme so it can't kill the erection. But
Yeah.
I want to really stress one thing you mentioned earlier. These drugs do not create the erection.
This is such a crucial point and a huge source of misunderstanding. They are not aphrodisiacs. They are not on switches. They only facilitate the mechanics.
So if you take a Viagra and then, I don't know, sit down to do your taxes,
Nothing is going to happen. You still need the psychological stimulation to start the whole cascade, to produce that cGMP in the first place. The drug just protects the cGMP once it's there. If you don't have the desire, the software, the hardware won't work, even with the pill.
let's compare the big four that are on the market. We have sildenafil, which is Viagra, vardenafil, which is Levitra, tadalafil, Cialis, and the newest one, avanafil or Stendra. What's the difference between them?
It mostly comes down to timing, duration, and food interactions.
Let's start with the classic sildenafil, Viagra.
The original.
Yeah.
Take it about 1 hour before you plan to be sexually active. It lasts for about 4 hours.
Yeah.
But, and this is a big but, you have to be careful with dinner. A high-fat meal significantly decreases its absorption.
So if you have a big greasy cheeseburger right before you take your Viagra,
It might not work, or it might work much less effectively, because the fat in your stomach blocks the drug from getting into your bloodstream.
good to know. Okay, what about vardenafil, Levitra?
Very similar to Viagra in timing, 1 hour before lasts about 4 to 6 hours. It also has that same issue with fatty foods. But there is a neat version of it called Staxin that's an orally dissolving tablet.
So it just melts on your tongue.
Melts on your tongue, no water needed, which can be convenient.
Then there's the one they call the weekender, tadalafil or Cialis.
This one was a real game changer because it addressed the spontaneity issue. Tadalafil has a much longer half-life. It stays in your system for up to 36 hours.
36 hours.
So you can take it on a Friday night, and it's potentially still effective on Sunday morning. It uncouples the pill taking from the sexual act.
And what about food with Cialis?
Food does not affect its absorption. You can have that steak dinner without worrying. They also offer a low-dose daily version, 2.5 or 5 milligrams, so you don't have to plan at all. You're just sort of always ready.
And lastly, the new kid on the block, avanafil, Stendra.
Its main claim to fame is speed. It has the fastest onset of action. You can take it as little as 15 to 30 minutes before activity.
Speed sounds good, but these drugs are not without side effects. And I want to get into some of the more unusual ones because the source material had a warning in there that sounded like something out of science fiction. It mentioned visual disturbances and specifically warned pilots.
Yes. This is one of those fascinating works of pharmacology where the word selective doesn't mean exclusive.
Okay, what do you mean?
So, we know Viagra, sildenafil, is designed to target the PDE5 enzyme. That's the enzyme in the penis.
The guy trying to slam the door shut.
Right. But evolution is efficient. Nature reuses code. There's a very, very similar looking enzyme in the body called PDE6. And guess where PDE6 lives?
I'm guessing not in the penis.
It lives in the retina of your eye, specifically in the cone cells that are responsible for helping you distinguish between blue and green colors.
Oh, wow.
Sildenafil is a potent inhibitor of PDE5, but it also accidentally inhibits PDE6 about 10% as much. It's not perfectly selective.
So it cross-reacts, it hits the wrong target.
It essentially confuses the retina for a little while. For the average guy, this might mean that for an hour or two after taking it, the room looks like it has a cool Instagram filter on it. Things might look slightly blue or hazy, a
The
cyanopsia,
literal blue pill effect.
literally. But now, think about the context for a commercial airline pilot. You are landing a 200-ton aircraft at night. You are relying on colored runway and taxiway lights, blue lights, green lights, red lights. If your color discrimination is compromised, even slightly,
That is a lethal safety hazard.
it's a catastrophe waiting to happen.
So the FAA actually has rules about this.
They are very strict about it. The FAA recommends a specific wait time, usually 6 to 12 hours after a dose of sildenafil, before a pilot is allowed to enter a cockpit and fly.
That is just incredible. Okay, so Viagra can turn your vision blue, but Cialis, tadalafil, had a different weird one. Back pain.
Yeah, this one really confuses patients. They take a pill for their penis, and they wake up the next morning feeling like they just deadlifted 400 pounds.
What is the connection?
This is because tadalafil, while being very selective against PDE6, has a bit of a cross-reaction with PDE11.
Another cousin enzyme.
Exactly. And PDE11 is found in high concentrations in skeletal muscle tissues, your lower back, your thighs.
So it's the same mechanism, just in a different tissue.
Yes. When you inhibit PDE11, you can get vasodilation and maybe some inflammation in those big muscle groups. It feels like a deep, flu-like muscle ache. It can hit about 7% to 30% of men who take it.
Does it go away?
It does. It usually peaks about 12 to 24 hours after the dose and then fades. But if you don't warn a patient about it, they think they've seriously injured their back.
Now, before we move on from these pills, we have to drop the hammer on the most dangerous interaction. We really cannot stress this enough.
This is the absolute #1 non-negotiable contraindication. If you are taking any form of nitrates, for chest pain, nitroglycerin pills under the tongue, patches, sprays, you cannot take these ED drugs, period. End of story.
Why? I want to understand the chemical mechanism here. It's not just low blood pressure, right? It's more than that.
It's catastrophic synergistic hypotension.
Yeah.
Think about it. Nitrates work by dumping a huge amount of nitric oxide into your system to dilate your heart vessels during chest pain.
Right.
PIs, the ED drugs, work by stopping the breakdown of CGMP, which is the chemical messenger that amplifies the nitric oxide signal. When you combine them, you get an effect that is far greater than the sum of its parts. It's like hitting the gas pedal and cutting the brake lines at the exact same time.
So the blood pressure just bottoms out.
It crashes. We're talking about a drop so severe and so rapid that it can cause a stroke, a heart attack, or even death. It is a potentially lethal combination.
Which is why.
That's why if you show up at the emergency room with chest pain, one of the first questions they will ask you is, have you taken Viagra or any similar drug in the last 24 to 48 hours? Because if they give you nitrates and you have a PI on board, they could inadvertently kill you.
Okay, message received, loud and clear, no nitrates with PIs. Now, what happens if the pills don't work? The source says the non-response rate is 30 to 40%. That's pretty high.
It is. It's not a magic bullet for everyone. If the pills fail, or if the patient is found to have confirmed hypogonadism, we might look at hormonal therapy.
Testosterone replacement.
Right. But let's be very, very clear about this. Testosterone is not a cure-all for ED. It is indicated only if you have confirmed low serum testosterone. Generally, a level below 300 nanograms per deciliter ND, you have the associated symptoms, like low libido.
So you don't just give it to every guy with ED?
Absolutely not. If your testosterone is normal, adding more won't help your erections and can cause significant side effects.
And there are different ways to get it into your body, right? Injections, gels, patches.
Yes, and the injectable forms are actually the preferred method from a medical standpoint.
Why is that?
They're very effective, they're surprisingly inexpensive, and because they're injected, they bypass the liver. Oral testosterone is rarely used anymore because of the risk of hepatotoxicity liver damage.
But the gels and sprays are really popular, and they have a very specific warning that freaked me out a little bit. Inadvertent transfer.
It is a very serious risk. If a man applies testosterone gel to his shoulders or his upper arms, and then he holds his child or hugs his wife before it dries,
The testosterone can transfer to their skin.
it can, and it absorbs very easily through their skin.
And what happens then?
You could accidentally dose your family. In women, it can cause hair growth, acne, deepening of the voice. In children, it can cause premature virilization, early puberty, genital enlargement in both boys and girls. It's dramatic and very serious.
Wow, so what's the safety protocol?
You must wash your hands with soap and water immediately after applying it, and you have to cover the application site with clothing like a t-shirt once it's dry. You cannot be casual about it.
Okay, so let's say pills fail and testosterone isn't the issue. We now move to what the source calls second-line therapy. And this is where things get a lot more invasive. We're talking about a drug called alprostadil.
Right. Alprostadil is a different kind of chemical. It's a synthetic prostaglandin that stimulates a different pathway. It increases CAMP directly, bypassing the whole nitric oxide GMP pathway.
Which means it can work for guys who fail on Viagra.
Exactly. Because it doesn't need that initial nerve signal as much, it can work even in men with severe nerve damage. But the delivery method is the major barrier.
Route number 1, intracavernosal injection. We are talking about putting a needle in the penis.
Yes. A very fine needle, like an insulin needle, is injected directly into the side of the penis, into the corpus cavernosum, about 5 to 10 minutes before intercourse.
I can literally hear the listeners flinching right now. That is a massive, massive psychological hurdle to overcome.
It is. Medically, it's very safe, and the pain is usually minimal. But the idea of it causes a very high dropout rate. The source notes that while it's effective in 70 to 90% of patients, a full 30 to 50% of them quit within the first year.
And why do they quit? I mean, aside from the obvious, it's a needle in my penis.
The source lists needle phobia, but also the unnatural or mechanical nature of the erection. It happens very fast, and it can feel artificial to some. Also, there's a risk of penile pain and bruising in up to 44% of men, and a much higher risk of priapism compared to the pills.
Priapism. That's the erection that lasts for more than 4 hours and won't go down.
Right. Because you're injecting a potent vasodilator directly into a closed space, if you get the dose even slightly wrong, the blood can get trapped. If an erection lasts more than 4 hours, the blood inside loses its oxygen, the tissue starts to become acidic, and it can die. It is a true medical emergency.
What do they do for that in the ER?
They have to drain the blood with a much larger needle. It is not a pleasant experience.
That sounds absolutely horrific. Is there a way to use alprostadil without the needle?
There is. There's a second delivery system called the intraurethral pellet, brand name Muse.
Okay, how does that work?
You use a small plastic applicator to insert a tiny medicated pellet about the size of a grain of rice directly into the opening of the urethra.
Into the urethra itself?
Yes. The pellet then dissolves, and the drug is absorbed through the urethral wall into the surrounding erectile tissue.
That sounds slightly better than a needle, but the source says it's less effective.
It is significantly less effective than the injection, and it has its own unique and problematic side effect.
Which is?
Because the drug can dissolve and travel with the ejaculate, it could transfer to the female partner during intercourse. It can cause significant vaginal burning or itching in the partner.
Not exactly a mood enhancer. Honey, hold on. I just need to insert a pellet that might make you burn.
Yeah, you can see why compliance and satisfaction rates are not particularly high.
Okay, we are really reaching the end of the line now. If the pills fail, if hormones are normal, and if the injections are either too much to handle or don't work, what is left? The mechanical and surgical options.
Right. First, you have the non-surgical mechanical option, the vacuum erection device, or VD.
The pump.
A pump. You place a clear plastic cylinder over the penis, create a seal against the body, and use a pump, either manual or battery-powered, to suck the air out of the cylinder.
And the vacuum pulls the blood in.
Physics takes over. The negative pressure draws blood into the corpora.
But how does the blood stay in once you take the cylinder off?
You slide a constriction band, basically a very tight tension ring, from the end of the cylinder onto the base of the penis to trap the blood. You then have to remove that ring within 30 minutes to restore circulation.
It sounds a bit industrial.
It is, but it's very effective and safe, especially for older patients in stable relationships who don't want to deal with drugs or needles. But it's slow. It can take anywhere from 3 to 20 minutes to work, and some men complain the erection feels cold or numb because you're trapping stagnant blood.
And finally, the absolute last resort, the penile prosthesis.
This is major surgery, the most invasive option.
What do they actually do?
A urologic surgeon physically removes the patient's natural erectile tissue from inside the corpora. The sponge is taken out, and it's replaced with a pair of inflatable silicone cylinders or rods.
And there's a pump.
Yes. A small pump is placed in the scrotum where it feels kind of like a third testicle, and a reservoir of saline fluid is placed in the abdomen.
And how does it work?
When the man wants an erection, he squeezes the pump in his scrotum a few times. That moves the fluid from the reservoir into the cylinders, and they inflate, creating a perfectly rigid erection.
And to make it go down.
There's a release valve on the pump. You press it, and the fluid flows back into the reservoir, and the penis becomes flaccid again.
That is a major, major commitment. You are essentially becoming a bionic man.
It is completely irreversible. Once you have this surgery, you can never, ever have a natural erection again because the tissue that does that is gone.
So who is this for?
It's for men who have failed every other therapy. Maybe men with severe diabetes or post-prostate cancer surgery where the nerves have been cut, but the source material is clear. Patient and partner satisfaction rates are actually very high, over 90%.
Really? Why so high?
Because it is completely reliable. It works every single time, on demand.
But the risks listed are intense. Infection, mechanical failure, and erosion. What is erosion?
Erosion is when the hardware, the tip of the rod, physically wears its way through the tissue and can even come out through the head of the penis.
Oh my God.
It's rare, but it's a catastrophic complication.
It's a sobering thought. So, to recap, we've climbed the entire treatment ladder. We start with lifestyle changes and checking your meds.
Right. Always start there.
Then you try the pills, the PIs like Viagra or Cialis, after getting a cardiac check.
Assuming you're not on nitrates.
Right. Then you check your hormones. Then you might consider the more invasive second-line therapies like injections or the vacuum pump. And only then, at the very end of the road, do you consider surgery.
That is the algorithm. It's a stepwise approach. You always start with the least invasive, least risky option first.
So wrapping this all up, what does this all mean for you, the listener? We started this entire deep dive by saying ED is a canary in the coal mine.
And that's really the take-home message. I think if there's one thing to remember, it's that ED is not a moral failing. It is not a reflection of your masculinity. It is a biological event. It is a check engine light for your entire body.
So if this is happening to you, the first step isn't to go online and buy some pills from a shady website.
Please don't do that. The first step is to go to your doctor. Get your blood pressure checked. Get your lipids checked. Get your blood sugar checked.
Because treating the ED might actually be secondary. It might lead you to discovering and treating the heart disease or the diabetes that you didn't even know you had.
Exactly. It might just save your life. It transforms the whole conversations from one about sexual performance to one about long-term survival.
And on that very serious but absolutely vital final thought, we'll wrap up this deep dive. It's complicated, it's chemical, and it's critical. Thanks for listening.
We'll get you on this one.